Hello, everyone. It's a great pleasure for me to be with you today in order to present one of the clinical cases that we titled Concealed Complexities, Traverse, Unforeseen Consequences. So here's our patient. It's an 81 years old female that got initially to our department for shortness of breath with an HI of stage 3. And during the workup, we found that she had aortic stenosis, severe one actually, with a mean gradient of 54 and the peak gradient of 88, with normal ejection fraction and also a good output. But however, she had also some degree of LVOT obstruction with a mean gradient of 34 with a dagger shaped and a late peak of the gradient. And also, visually speaking, she had asymmetrical septal hypertrophy associated with some bulging of the septum. So we go on, we measure the septum. Here it's a bit overestimated, but it's around 18 millimeters. And as all the patients during the workup of TAVRs for these patients, we perform coronary angiogram. And here it was without any obstruction of coronary arteries, neither in the left system or the right system. And we go on also with the invasive measurement of the gradient across the valve and the LVOT, which shows to be 64 at rest. So we're ready to go on with our workup for TAVR, and we perform our CT that shows an area derived of 21.5 and a perimeter of 68, the height of the cusps, and the height of the coronary outtake, which shows to be nearly around 10 millimeters, so there's not much risk of coronary obstruction. So in these cases, we can go either with self-expandable or balloon-expandable valve. And for the feasibility from the femoral approach seems to be okay. So how would we approach this patient? So we decided to go with the TAVR, and we go on with the self-expandable valve and with its 26 self-expandable core valve Evolut R. The implantation goes without any incident. Everything seems to be okay. And to this level, we can say that our implantation was successful. However, the patient doesn't feel good. She had a post-procedural complication of arterial hypertension, pulmonary congestion, and atrial fibrillation. So when this happens after, immediately after TAVR, we think either with subacute thrombosis or acute high degree of aortic regurgitation. So we try to see what's wrong with the valve. But actually nothing was wrong with the valve, but it was more a significant LVOT obstruction with a pronounced systolic anterior motion. And from 34 that we saw before, now it rose to 58. Here, what's next? How could we manage this patient? So conservative therapy actually is quite complicated in these cases because beta blockers in the setting of pulmonary congestion is not the best solution, neither the bolus of hydration. So we decided that the best therapy could be a semi-urgent transcatheter alcohol ablation, which also would go without difficulties, and it was scheduled 7 days later. So just like to give some time to medical therapy if that would succeed anyhow. So for the invasive measurement, demonstrated extreme gradient actually, which was around 155 at rest and post-extrasystole with 258. So we need absolutely to do something. And for TASH, actually there is two hurdles to overcome in this case. The coronary access, and actually we had supraannular valve with difficulties of access, as all of us know, and which septal should we select as long as we don't want to create neither AV block nor septal perforation. So that was our target, and here we are with echographic guidance. We went with dual radial and femoral 6 French sheet with GL 3.5 6 French with the guideliner. I just need out of the way. And that was our target. So we went with over the balloon 1.5, 0.6, and we inflated first in order to stabilize it and also to not allow any leaking of the alcohol towards the LED. We injected 2 ml of alcohol, and that was our final image. Did it help? We did pulse control, which was 27. So clearly the patient also did well. Also echocardiographically, it was better. So this is our measurements in comparison. So the take-home messages are from this clinical case that there is a huge interaction between aortic stenosis and LVOT obstruction, and it's a challenging diagnosis that we need to be aware of. The treatments of aortic stenosis can exaggerate the impact of the obstruction, and aortic septal ablation after TAVR is a technically challenging, so we need to think that beforehand. Thank you so much.
Very good. Any questions?
Yeah, I got 2 questions. Did it surprise you this happened?
Actually, it was a bit expected, but not to that extent, because, I mean, the question is that should we perform septal ablation before? So when it is a bit unpredictable, we could not do much about it, just crossing fingers before.
Yeah, that was going to be my question. What would you do different next time to prevent this?
I mean, I still would not do anything differently, to be honest. I mean, I would not propose the patient.
I would. I mean, one, you know, this is anticipated. So we didn't see, you know, well, the pre-echo and the CT scan, but you know, these in little old ladies like this with hypertrophied ventricles, I mean, this is an expected consequence. So, you know, a couple things. One is you can do an alcohol septal ablation ahead of time. 2 is you can do surgery instead and do a septal myectomy at the same time, do an aortic valve replacement. Or if you're going to go ahead with TAVR, volume load these patients ahead of time and beta block them ahead of time so that they don't have the vascular collapse that happens afterwards. Yeah. That would be my takeaway from this.
Yeah, I mean, I totally agree, especially like on the medical treatment, because I still would not propose these patients with like surgical candidate for 81, but still for the medical treatment, I would completely agree. Thank you.
All right, any questions?
It's just, it's an important teaching point that you are fixing the fixed obstruction, so you unmasking the dynamic obstruction that happens. So that's what our practice have been now. If we see concomitant LVOT obstructions with the severe AS, we try to chase or like treat the septal first, or surgery, as Dr. Mack recommended, might be a better option for these patients.
And usually wait 3 months. Remember the timeline which I showed, the patient with septal ablation we did, it takes about 3 months for septal to get thin. And we now have done probably about 20 cases so far. We published in JACC intervention of 8 cases, and we've been quite successful. But very good.
Thank you.
All right.